Good evening, everyone. This is the 20th session of our Ocular Genetics Interest Club. Today we have two presentations, clinical genetic presentations. The titles are Unraveling the Mystery of Abnormal Head Posture and the Phenotypic Spectrum of CPAMD8 Gene. Our first presenter is Dr. Sirisha. She is the head of glaucoma services at LVPEI with 23 years of experience. She specializes in managing refractory adult and pediatric glaucoma and has cultivated a profound interest in glaucoma drainage implants, secondary glaucoma, and the genetics of inherited childhood glaucoma. She has various papers in peer-reviewed journals, and she has multiple awards to her name, which include the Dr. Wengal Rao Medal in 2012 and the American Academy of Ophthalmology Achievement Award in 2018. The next speaker is Dr. Aloka. She's senior pediatric ophthalmologist with 15 plus years of experience. She is the founder of Dr. Aloka's Eye Care in Hyderabad. She's an expert in nystagmus, strabismus, paralytic squint, and neuro-ophthalmology. And she has multiple publications in peer-reviewed journals. I would like to welcome both the speakers. If any speaker has a preference to go first, we can start.
Yeah. Can I start if that is okay?
Yes, please, ma'am.
This is also the scanner to join our WhatsApp group. If anybody is not there, we post our updates there regularly, so you can join.
Is that okay? Is my screen visible?
Yes, ma'am.
Yeah. So this is something that I thought I'll share because we learned this in a hard way. So I'll start with a case. This was a 21-year-old boy.
Yeah. Are you speaking, Dr. Sirisha? We couldn't hear you in the last few seconds.
Can you hear me now?
Yes.
Yeah. So I said the couple of cases from which we learned something, and I thought it will be good to share. So this was a 21-year-old boy who was actually posted for a cataract surgery with me in my list, and I had not seen this boy earlier. And then when I saw him with torchlight, there was something very striking. So I didn't want to operate, and I said, let me take a look and evaluate before I touch this eye. Okay, so he actually had presented to the general ophthalmology clinic with diminution in vision of 1 month duration. He was the second born child to consanguineous parents, and there was no history of any trauma prior to the presentation. His right eye was 20/20 vision and left eye was counting fingers close to face. His intraocular pressures were normal, and he had huge corneas, and there was Hab striae that was noted. Okay, so because he had Hab striae and the corneal diameter is enlarged, I thought somebody had missed a primary congenital glaucoma. I would like to reevaluate and then only touch the eye. So that's how I postponed the surgery. And his optic discs in the right eye optic disc was healthy, and left eye, because of the intumescent cataract, there was no view of the fundus. Okay, so this was his appearance. You see that left eye had a lot of fluid vacuoles and clefts, and there was an intumescent lens. And there was some amount of ectopia, the ectropion UVA, as well as there was a pupil which was, I wouldn't say completely ectopic, but there was slight ectopia of the pupil, more on one side compared to the other side. And if you see, his white to white was 13.5 in one eye and 13.7 in the other eye. And the central corneal thickness was reasonably fine, and anterior chamber depth, if you see, was quite deep anterior chamber in one eye compared to the other eye. Okay, and his cell density was less. We did this because we wanted to make sure, because he had his Hab striae, was there any other problem? and his corneal, the endothelial cell density was less compared to what you would actually see for a 21-year-old. And this was his keratometry. So what we had differential diagnosis was a spontaneously aborted primary congenital glaucoma, or maybe an anterior segment dysgenesis, or a keratoglobus, or a primary megalocornea. So all we had was a very large corneal diameter, and there were HAP striae that was noted. And so we said we have to do a evaluation before we touch this eye. He was scheduled, like I said, he was scheduled for cataract surgery. But then I said, let us wait if it is possible for at least 3 or 4 weeks before we touch this eye. And we also screened the sibling on the same day. This was his disc appearance and fundus appearance. It was completely normal. This picture was taken post his cataract surgery, but I just wanted to share that his discs were otherwise healthy. So to say somebody had a spontaneously aborted congenital glaucoma, it's unlikely, but can happen, though it is very rare. So the younger sister also had accompanied, elder sister had accompanied, and then we evaluated her as well on the same day. She was the firstborn child to consanguineous parents, and then she actually had elevated intraocular pressure. Right eye was 25 and left eye was also 25. She had open angles and there was some amount of dysgenesis noted, and she had megalocornea but no HAP striae, and she also had a posterior subcapsular cataract in both her eyes, and the discs were healthy as well. So this was the dysgenetic type of angle with very prominent iris processes, but otherwise we could not really identify any angle structure. And she also had some amount of correctopia, and there was ectropia and uvea noted in both the eyes. And she had this posterior subcapsular cataract, and this was a hazy view because of the cataract, but discs were essentially healthy. And she also had a white to white, which was very large, 14.15 in the right eye and 14.35 in the left eye. And axial length was reasonably okay. It was not a very high myope. Okay, so this was the anterior segment OCT. You can see a deep anterior chamber. Obviously, you can see the concavity of the iris. And there was a very high insertion of the iris. And then there were we could see the Schlem's canal, but otherwise this was a dysgenetic angle. And her cell density also, though she did not have a HAP striae, the right eye showed lesser cell density compared to the left eye. And there were thin corneas in both her eyes. Though and for differential diagnosis here was possibly an anterior segment dysgenesis, and because she had elevated intraocular pressures and she didn't have very thick cornea, so basically you've ruled out if you are dealing with a thicker cornea and an overestimation, and we started her on topical anti-glaucoma medications. So when we did the genetic testing for both of them, the whole exome sequencing was done for the brother. He had a likely pathogenic variant in CPAMD8 gene and homozygous. And the sister, we did the both the mother and the sister were also tested. The sister was homozygous with the same variant that was noted in the CPAMD8 gene, and the mother was actually heterozygous and was a carrier. This boy had lost his father recently, and we could not obviously get the father's thing, but mother was unaffected. So it just tells us that she was a carrier, and possibly the father was also carrier. And because they were consanguineously married, and both the kids were having a homozygous autosomal recessive kind of an inheritance pattern and a mutation in the CPAMD8 gene. Okay, so we then came to know that this was a CPAMD8 associated possible anterior segment dysgenesis, and this was the pedigree chart. So what is CPAMD8 gene? Complement component 3 and pregnancy zone protein like alpha-2 macroglobulin domain containing protein 8. It plays an important role in the ocular extracellular matrix formation and ocular development, and it has an autosomal recessive form of inheritance. So this extracellular matrix is necessary for ocular development, and whenever there is a break, or if there is some kind of a derangement in this, and this can lead to abnormality in the extracellular matrix and problems with the ocular development as well. So CPAMD8 variant typically inhibits the TGF-beta to BMP signaling pathway and thereby influencing the maldevelopment or ocular development is kind of effective. It is present in the ocular fluids as well as in the anterior segment tissues. It's expressed in the neural crest cells. However, no systemic manifestations are reported yet. But like I told you, this boy's father passed away because of a cardiac ailment, and we really don't know what that cardiac ailment is. Until now, whatever is reported in literature, this is supposed to be affecting only the ocular tissues with no systemic, no literature is. This is a paper that was published in 2016 looking at the mutations in CPAMD8 and with a unique form of autosomal recessive anterior segment dysgenesis. They have also reported nasal coroctopia, ectopia lentis, persistent pupillary membrane, focal ectropia and UVA, and some of them also had transillumination defects in the iris. And there was one case which actually showed a correctopia. So there is a huge phenotypic variability in these patients. Some of them, there was one patient, I think there was one study where the two patients also showed microphakia, and there was some iris hypoplasia also that was noted, and foveal hypoplasia, optic nerve dysplasia was also noted, and there was none with glaucoma, but at least in this particular series, but one patient had ocular hypertension bilaterally. And there was no Descemet's membrane split that was noted, although all of them had enlarged corneal diameter. So what is known is that there is enlarged corneal diameter, there is possibly some changes in the lens, and there are iris changes that are noted, pupillary changes that are noted, and they also can have elevated intraocular pressure. This is what is actually available in literature. Some of these eyes can also have retinal detachment. So that's something that we did not see in our series, but this is something that can be noted as well. And in one of the patients, there was also HAPS striae that was reported in a series by Siggs et al. So what was the confusing feature here? There was megalocornea and there was HAPS striae. So this any corneal diameter that is more than 12 millimeters, we know that whenever there is a stretch in the corneal diameter, there could be HAPS striae. HAPS striae is breaks in the decimates, and typically this is seen with enlarged corneal diameter, especially if somebody is younger than 2 years of age. But in this patient, these two patients, if you see, there was one boy who had enlarged corneal diameter with HAPS striae, but there was this girl who was his elder sister who had much larger corneas, but there were no HAPS striae. Whenever we see somebody with an enlarged corneal diameter, we always should rule out if this is an isolated megalocornea, or are we dealing with primary congenital glaucoma or any other form of anterior segment dysgenesis, and do these patients also have other systemic features, so that you need to rule out other syndromic associations as well. So just to, this is something that we have put together. So there are 3 things that we need to remember. Isolated megalocornea with no other anterior segment abnormality and no other posterior segment abnormality and no other systemic abnormality. Or are you dealing with primary congenital glaucoma, or is it an anterior segment dysgenesis? In anterior segment dysgenesis, remember that LTBP2 also can have similar kind of features, but there are some differences that are there that I will come to. So this primary megalocornea is something this we had discussed earlier also with relationship with LTBP2. So we need to remember, if there is only isolated megalocornea with no other pathology, no subluxation of the lens, no zonular weakness, no other posterior segment abnormality, then possibly you are dealing with isolated megalocornea. So this is one such patient who had CHR-DL1 involvement, and this was an X-linked megalocornea. So you don't have to really do anything here. You just have to observe and keep following up these patients. There's one more differential diagnosis that we have. It could be a very young child, as young as 4 months old, or a patient who is 10 years old. They may have enlarged corneal diameter. Usually these eyes don't have any HAPS striae. So there is a megalocornea that is there, and it is not enlarged after birth. I mean, enlargement is similar to what you would see age appropriate maybe, but they are enlarged corneal diameters at birth itself, and they typically have subluxation of the lens. So ectopia lentis is more common. In LTBP2, the main difference is that the ectopia lentis or the subluxated lens is much more common. And as the child grows older, you may actually see a dislocation of this lens either anteriorly or posteriorly. So the primary abnormality here is in the zonules. Okay, so this is again a autosomal recessive condition that you see, similar to that of CPAMD8, but in CPAMD8, the presentation is slightly different. So the actual difference is just concentrate on this LTBP2 and CPAMD8. Both are autosomal recessive, both are progressive. They may have elevated intraocular pressure or normal intraocular pressure. Both have megalocornea. In LTBP2, at least until now that we have, whatever patients we have seen, we have never seen anybody with a HAP striae. While with CPAMD8, there was one patient who had a HAP striae, but the others did not have. You can have the iris stromal changes, pupillary changes in the form of keratoconia, ectropia, and uvea. And iridodonosis is also something that can be associated in these patients, especially when you have a very deep anterior chamber. Ectopia lentis is a commonest feature that you see in 100% of these patients with LTBP2, while ectopia lentis may or may not be present in CPAMD8. And you can, like I said, axial length can be increased or maybe normal as well. So these are the two basic differences that you see. So I would also like to show, while I didn't want to present details of these cases, but remember that this is something that we have come across in the recent time, where if these two are babies who are born with congenital glaucoma presented to us at less than 1 week of age. So these patients have very typical microphakia, meaning the lens is very small. So it's like a microspirophakia, if you want to call it as. But there is no broken zonules, there is no displacement of the lens at this point in time. So very small lens, elongated zonules, and they have anterior segment dysgenetic features like, there is ectropia and uvea, iris hypoplasia. You can have prominent Schwab's line, as is actually noted in ASOCT here. And you can also have partial aniridia-like picture. So this is something that we have seen. The neonatal onset CPAMD8 can actually present with this kind of features. And both of these patients were also homozygous with CPAMD8 variant noted. And both are autosomal recessive. So this is a different form of presentation. So one was a juvenile onset, the other one was neonatal onset, and they had very different presentations in both the cases. So that's all about the cases, and then we can have discussion if you would like to.
Yeah, thank you, Dr. Sirisha, for that beautiful presentation. So ultimately, to differentiate between the CPAMD8 and the LTBP2, it's the frequency of ectopia lentis, which is much more common in LTBP2.
Yeah.
Otherwise, almost similar.
Yeah, almost. So when you say almost similar, the similar features are presence of megalocornea. Yeah, and the lens can have a microspirophakic appearance. But in LTBP2, what happens is the zonules that are abnormal, brittle, and so when we say ectopia lentis can start as early as 3 to 4 months of age. The reason being, because the zonules are brittle, as soon as the child starts fixating, starts having saccadic movements, that is when the breakage can happen.
Okay.
So as early as 4 months, you can start seeing subluxation of lens. In fact, this is one condition among the conditions where ectopia lentis can be present, that can present at the earliest.
Yep.
So at least I haven't come across any other type of ectopia lentis where you can actually see subluxation dislocation as early as 3 to 4 months of age. Whereas in CPAMD8, you don't see, because when we reviewed the literature, there were patients who were even 60 years old who presented with CPAMD8 with a cataract, but may or may not have. So even at 60 years of age, they did not have a dislocation of lens.
Dislocation of the lens.
Yeah. So that whereas in
But they do have microphakia. They do have small lenses, maybe a little bit ectopia, but they don't dislocate that often as compared to LTBP2. So if
correct.
you are seeing a dislocation in a very young child, so with a megalocornea, think about LTBP2.
Correct. Here. And LTBP2 is also associated with much higher rate of retinal problems compared to
Okay.
CPAMD8. At least CPAMD8 in the current series that we have seen, we haven't come across the retinal problems, but then it's too early. We all learn with time. But what they have is typically all of them have cataracts, all of them have microphakia. The size of the overall size of the lens is smaller, and they have cataract, especially if they're presenting at a later time point. Whereas
Yeah.
the child, that is the children with this, so that they can present with a congenital onset glaucoma was also something that we learned only recently. Because when you see all of these eyes are actually grouped as PCG. They are not PCG, you know that. Otherwise, they'll be grouped as microspirophakia. Again, not knowing what the problem is. So understanding this pathology, understanding that these eyes behave differently is very, very important, because then your treatment is not similar. And of course, you have to understand that this is autosomal recessive. So inheritance pattern and understanding that the sibling risk is also something that we need to be aware of.
So what did you finally do for the cataract for this patient, ma'am? And because they're microphakic, then do we leave them aphakic?
No. So he didn't have any zonular weakness. I could go ahead and do, of
Oh, he
course,
didn't have.
it was intumescent, but I could go ahead and do a cataract surgery without any problem. So
Okay,
that's
so this patient didn't have that
yes.
ectopia and other thing. But is there a risk of developing that with age?
May develop, but the zonules were not that bad at all. I mean, you could comfortably do a rexus and put in a lens in the bag.
Savleen is asking some questions. Savleen, you can unmute and ask. Can you do that, Savleen? Basically, she's asking that she had one case of CPAMD8 with only cataract, no glaucoma, only cataract.
Yes. Yeah. So even this boy also, he had only cataract, he didn't have any glaucoma at that time point,
Mhm.
have any elevated intraocular pressure. But when we examined the sibling, that girl had elevated intraocular pressure. So we have a few more patients also. Of the older children that we have seen, glaucoma, at least nobody has had a damage as of yet. But two of those people had in both the eyes, that means 4 eyes, they had elevated intraocular pressure. So we need to keep a watch, because glaucoma is something that they can develop in the future as well. Okay.
And how do you
The
explain
neonatal onset ones, we have a few more patients as well. All of them had bilateral glaucoma, and is very difficult glaucoma to treat. Though we have done a trab and we are able to take care of the pressures temporarily, one of the students now is requiring additional surgery. So it's not like a typical PCG where you do one surgery and most of them do okay. But these eyes, because they have iris abnormality and angle abnormality, they may require a very severe ectropion. So I believe that whatever you're seeing as almost aniridia-like picture with a microphakia should give you a clue that you're dealing with CPAMD8.
CPAMD8? And is the variant different in them? The ones which are
So each one had different variant. Of course,
each
each
one a different
family had
variant.
a different variant, but there was no genotype-phenotype correlation for the neonatal and the juvenile ones. Meaning like all of them have a certain type of a mutation. It's not like that. At least we didn't see any trend towards a similar type of mutation for the childhood, for the neonatal onset one versus the juvenile onset. But it's very small piece, because now we are seeing this as possibly the third largest after LTBP2. So CYP1B1 is first, then you see LTBP2, and then CPAMD8 for the neonatal onset glaucoma that we are seeing, or the childhood onset glaucoma, or the infantile onset glaucoma, if you want to call it.
Okay. And what about the tech, which is reported to be the second most common in otherwise literature?
But not as much as we have seen these.
Okay, maybe because autosomal recessive population around you
Is more common, yes.
Yeah, maybe. And
Tech
ma'am,
we
how do you, I'm sorry,
have
all
seen.
questions coming from me.
Yeah.
Yeah. No, you were saying something?
No, so tech we have seen, but not as many, maybe 2 or
As
3
many.
the entire group. Yeah, I agree,
Mm.
because more of possibly autosomal recessive.
Yes,
And
yes, yes.
the population that we deal with more of consanguineous marriages.
Okay. And ma'am, how do you explain the HAPS try in one patient actually and the other one
So
having an erased IOP but no HAPS try?
exactly. So I don't have much, and I mean, the only hypothesis that I can give is possibly this child had elevated intraocular pressure at birth, or maybe in the
In the
infancy.
first two.
And so, like most of these, sometimes when you see spontaneously resolved congenital glaucoma, what happens is you can see that even in Axenfeld Rieger's anomaly, where possibly that when you have a detached Schwalb's line, so whatever
Mm-hmm.
anteriorly inserted iris that you have, so if you have a detachment of Schwalb's line, along with that, all these adhesions also get detached, and suddenly there may
Okay.
be opening up of the angle where the fluid is able to.
Final.
So similar to that, here you don't have a detached Schwalb's line, but I'm just saying that similar to that, like in a PCG or in a Axenfeld Rieger, where there is a possibility of a spontaneous angle, refunctioning with the development, or where maybe that there is a posterior push of the iris attachments or the angle attachments, which possibly allows the angle to start functioning. I can only think of that as a cause. The other thing we need to remember is that these eyes with megalocornea is a primary megalocornea. That means there's something abnormal in the ciliary ring development itself, where so megalocornea can happen as a response to elevated IOP, or primarily by developmental itself, they can have enlarged corneal diameter. So this child possibly has both. By development also, there is an enlarged corneal diameter, and possibly was exposed to high IOP at a very young age, and then that resulted in HAPS trait.
Yeah. Yeah, that's the most plausible explanation here. Any other questions from any other person? People can actually unmute and ask themselves.
Yeah, thank you, Dr. Shiva, for a very wonderful presentation. I had just one question. We had one syndrome, very rare syndrome of oculoskeletal dental syndrome, PIC32. So that child also had megalocornea, and the sibling also. That child had so many things like dental anomalies, megalocornea, high myopia, secondary glaucoma, and macrocephalic cleft lip, cleft palate. And the sibling had a sibling when amniotic fluid, sibling had only megalocornea. So whether you are having any experience of this PIC32, actually this is very rare syndrome. So whether
I
you have
have
discussed.
I have not seen any of those, Dr. Neelam. Maybe others,
Yeah,
if they have experience, they can tell. But yeah, so
yeah.
this megalocornea is kind of an enigma.
Hmm.
So we used to think megalocornea is synonymous with congenital glaucoma, but not so. So with or without HAPS tray and presence of megalocornea, it just tells you that there is some abnormality in the area of the ciliary body.
Yeah.
So that possibly, so from what I understand, I don't know, this is there, I haven't come across any good explanation for this, but what I understand is that because of the abnormality in the ciliary ring, so if
Yeah.
suppose the ciliary ring is at a particular size and it stops there, it is supposed to come down and stop, let's say, at 10 millimeter size. And then your cornea comes and covers that area, or connects from one side to the other side. Suppose the ring is not coming down, the size is not coming down and stops short at 12 millimeter or 13 millimeter, then the cornea also tends to cover from one edge to the other edge. And so usually these eyes have thinner corneas, and possibly also can have normal thickness of the cornea, and they're just covering from one edge to the other edge, and by development itself, like at birth itself, they can have a very large corneal diameter. This is the understanding that I have in a layman's term. So yeah, maybe others can add or suggest if this thought process is correct or not.
No, thank you for this insight, because actually it is very rare syndrome. It is the 9th syndrome in the world, that PIC3 C2A gene or oculoskeletal. So even the reviewers were like that when we submitted for ophthalmic genetics. Reviewers were like that. We have to find whether this is it's the megalocornea, because the proband and the sibling both are having megalocornea, but the proband is having all the other features of this syndrome, but sibling is having only megalocornea. So whether this is the feature of the syndrome itself, or whether some other gene responsible for the megalocornea is there. So I think with all the genes you told, like if we are having some megalocornea panel, like we can look for the isolated megalocornea in that sibling.
So, have you done the sibling testing also, Dr. Neelam?
Yeah. Sibling test first done.
With whole exome or only the PIC3?
No, only with the PIC3.
Yeah, so maybe doing a whole exome of the sibling might throw some light. Maybe that megalocornea gene gets picked up if it's a separate thing, and then you can check for that in the proband using a Sanger. Or you can check you can ask the lab to look for other megalocornea gene in the proband itself, in the whole exome data. Because
Yeah.
sometimes they don't report things if specifically you have not mentioned megalocornea in the phenotype, or even if you have mentioned, if the bigger phenotype or the more worse phenotype is matching, they may have reported just that and not the other gene. So this could be like a dual gene thing. Could be two
Yeah.
genes and two different diseases which might be there. 8 o'clock.
Yeah. So maybe for the sibling we have to, because for the child proband itself and for family, whole exome sequencing was done, but for the sibling I am not sure. Sibling
Yeah. So first and foremost, it would be good to just ask the lab to go through the whole exome data and look for megalocornea, genes.
yeah.
That
Okay,
might even
thank
just throw some light. Yeah.
yeah. Thank you so much.
One last question, Dr. Sirisha, before we move on to the next speaker, is that many a times patients who have been diagnosed with PCG, the ones with really that half stripe, ophthalmos, and all, when they come for cataract surgery from me, we still see that the zonules are stretched and the bag is little smaller than the normal. That's because, because of the enlargement of the cornea, the ciliary ring is expands. And this is not like from birth, it's like later on that it happens, but the same mechanism would be there. And because of the stretching of the zonules, the lens becomes even a little bit more spherical also. But at that point of time, because we know that it's a case of PCG and now developed cataract, I haven't really labeled them as a microphakia or a microspherophakia. And now I'm wondering, maybe they were, some other syndrome to begin with, like a CPAMD8 or something else, where the microphakia had been there from the very beginning. Because not all patients with PCG have a smaller, bag when we do cataract surgery.
I agree with you. So these things, like, see, the kids that I showed you, why I wanted to share this is something that I learned. Now, one case, if you see, I don't think you forget this in your lifetime. Because here we see congenital aniridia again presenting with congenital glaucoma, neonatal onset, that means they're born with glaucoma. So when you have an aniridias don't have microphakia. You have equator to equator, which is very close to the corneal limb.
Close to cornea, yes.
So that is different. They also can present with congenital glaucoma. So very easily, these eyes can be just labeled as aniridia or microspherophakia and left like that. So the only thought that I have is we shouldn't dump them into a common diagnosis. Partial aniridia, complete aniridia, जो चाहिए वो बोल सकते हैं, or microspherophakia. And then if you don't understand these, we will unnecessarily be either evaluating them for a Wilms tumor or evaluating them for a cardiac abnormality if we don't actually group them into a certain disease. So we need to understand presence, absence of iris doesn't mean it's aniridia, or just the absence of iris alone or a partial iris again does not put them into that category. So that's also something that I would like to highlight, because understanding these, like what you said, they can present at birth also with congenital glaucoma. And maybe because these eyes are more often developing cataract, you don't know, maybe you're dealing with that eye and then you're trying to say that, they are enlarged zonules and maybe they're associated with microsporifica. Typically, in primary congenital glaucoma, you should not have microsporifica. If we are having that, then that means we are dealing with some other anterior segment dysgenesis, which is possibly labeled as a PCG. Sometimes you see very subtle changes, like Schwab's line, or very subtle changes of correctopia. You may not even, you may just say that this is, non-dilating pupil or improperly dilating pupil. You may not know what the diagnosis is, and it may not be PCG at all.
Yeah, agreed. Thank you.
Yeah.
So we can move on to the next speaker, Nivedita.
Yeah, Dr. Aloka, you can present.
Yeah, I'll just share my slides. Just a second.
Hi, Aloka.
Hi. Just
Thank
a
you
second.
for volunteering.
So, no, I mean, I will begin by saying that mine is not a series of cases. It's a kind of a case presentation. I'll need all your insights, so please help. So, are you able to see my slides now?
Not yet. Just the screen with the folder. I think your slide is opening.
Is it
Maybe
not coming as
okay.
yet?
No,
I'm
not yet.
able. Just a second. Please give me some time.
Try sharing again. Yep. We can see your presentation. Can you make it slideshow? Let's see if it works.
It's not converting into a slideshow. Yeah. Is it visible now?
Yep.
All right. So I have this 14-year-old girl who came in April 2023 with a history of head shaking. Now she had intermittent head shaking and her refractive error was a mixed astigmatism. She was improving to 6/6 parts or 6/9 in each eye. And she's somebody whom I had operated at 5 years of age. So that was in 2016, and I had noted a similar refractive error and operated her. At that time she had 30 prisms of esotropia. There was no nystagmus noted, and I had done a bimedial recession of 5 millimeters. Now, as evident in the picture, she had no milestone delays and no other neurological issues noted at that time. Now, today when I see her, her anterior segment was normal, and her orthoptic evaluation showed a good squint. So there's only a small exophoria for near and distance, a good binocularity and stereopsis, no nystagmus, no diplopia. But I noted this particular type of, I don't have her particular video, but this similar kind of ocular motor apraxia noted in this girl. Now, on her fundus evaluation, I saw bilateral disc edema, if right eye much more than the left eye. And, typically, if you see in the periphery, there is all these kind of vessel attenuation and lot of RPE changes that I see. It's seen more in this picture here, where the entire retina was covered in these kind of pigmentary changes. So I went ahead and did an ERG, which showed almost flattened curves. Both rod and cone responses look pretty abnormal, and so I saw some cone rod dystrophy here. Now, I sent her for a neurological assessment, and my pediatric neurologist found no particular neurological or cerebellar signs, but she did notice some intermittent head nodding and some hand tremors. Now, with this, we have this child with head nodding, disc edema, subtle visual acuity defects, mottling of the retina, rod cone dysfunctions, and a previous squint surgery. So I went ahead and did her OCT disc, and I saw some a little RNFL thickness, not very high, a little RNFL thickness noticed there. And ultrasound B scan shows this typical kind of a nodule which is seen just above the optic disc level, matching with the A scans, showing optic disc drusen bilaterally. Now, also in the autofluorescence, you see a subtle hyperfluorescence near the optic disc areas, and all throughout is showing this kind of RPE changes that we see on autofluorescence. So now we went ahead with neuroimaging, and here initially it was reported as normal, and then again reassessment by a neuroradiologist showed subtle changes where there is typical cerebral vermis hypoplasia, a thickened, elongated superior cerebellar peduncle, and a deep interpeduncular fossa. So what we all know as molar tooth sign was seen in this child, and we came to a tentative diagnosis of maybe Joubert syndrome. We went ahead with whole exome sequencing, where we saw heterozygous missense mutation in both exon 7 and 8 of INPP5E gene. Now, both the variant 1 and the variant 2 had shown the missense variant in the variant 1 of exon 7 IPP5E gene, whereas in variant 2 we saw silent variant, and both of these due to lack of literature evidence was classified as variant of uncertain significance. So what is Joubert's? We always see Joubert's more common in our Indian population because of autosomal recessive condition, and characterized by dysgenesis of cerebellar vermis with the typical molar tooth sign, brainstem anomalies, hypotonia, ataxia, irregular breathing patterns, and abnormal eye movements. Now, if we see on the left is the normal axial MRI and the coronal MRI, but if you see here, we have typical cerebellar vermis hypoplasia and the superior cerebellar peduncle prominence giving a molar tooth sign. So we have JSRDs, which also are seen commonly, where we can see sometimes occipital encephaloceles. These patients can have polydactyly, or they might have this typical, flat forehead or high arched eyebrows with ptosis. And some of them can also have a cleft lip, cleft palate. More importantly, they are associated with systemic issues like cystic kidney disease, nephronophthisis, or hepatic fibrosis. So now when we see diagnostic criteria for classic JS, it needs to have MRI findings, hypotonia in infancy, developmental delays, or at least one of the two supportive for diagnosis like breathing difficulties in infancy or eye movement disorders. Now this case, as we see, has only eye movement disorders and MRI findings, but this child had good developmental milestones achieved. She was doing very well in school. She had no motor or behavioral abnormalities seen. Then are we dealing with GSRDs and not classic GS? So additional tests, I did ultrasound of abdomen, renal function, and liver function test, and they all came out to be normal. No cyst was noted in the kidneys. Then molecular genetics in Joubert's. NPHP1 was one of the first diagnosed gene, and now we have close to almost 40 genes which have been recognized in Joubert syndrome. Joubert's with retinal dystrophy is common in 24 to 32% of patients. One of the common genes that we see is AHI1, ARL3, and CEP290. And this is an entire list of all the genetic disorders which are noted with Joubert's. Like we know, we can have Joubert's with only a renal anomaly, or Joubert's with hepatic disease, or Joubert's with retinal diseases. And in this list, we notice that we have common is AHI1 and CP290, and INPP5E also is one of the ciliopathy causing Joubert syndrome with retinal diseases. Now, what does it do? It basically, INPP5 gene, it gives an instruction for making enzyme inositol polyphosphate 5-phosphatase E, which is very crucial for regulating cell signaling, especially in the cilia. And that's why we see all these ciliopathies causing multiple organ involvements like the kidney, the liver, as well as the retinal pigment epithelium, or outer retinal epithelium damage is common because of the ciliary dysfunction. Now, optic disc drusen, which is seen in my case, is noted, but it's a little rare. Optic disc drusen mimicking papilledema has been noted in infants with Joubert syndrome, and most of the children with optic disc drusen also have retinal dystrophy of some kind. So they are usually seen together. Now, Joubert syndrome. So my case now has, if we can put it as, INPP5 gene mutation of unsignificant variants has been noted. And what are the features that we have is strabismus, optic disc drusen, retinal dystrophy, oculomotor apraxia, head nodding, and some tremors. Now, as we know, Joubert's is a progressive disease. So why I couldn't see it at 5 years of age may have been that the disease had not manifested as much at that age. And now 10 years later, when the child is coming to me, I am seeing retinal dystrophy as well as the other oculomotor apraxia and other signs. So we may have to keep monitoring this child for systemic issues also, because renal disease or hepatic diseases can manifest later in life and they can change the phenotype, and therefore genetic evaluation again later might help prognosticating the disease further. So thank you.
Thank you, Dr. Aloka. Again, wonderful presentation. So, why do you think that this is, not showing all the symptoms? Because of the IMPP5, yes. It could be
Yeah,
a lesser severe
ocular
variant.
symptoms. Yes. So what we found is that this variant that we have found here is a lesser manifesting variant, in the sense that, as we know, we see some Joubert's with LCA kind of retinal dysfunctions also, where the vision loss is very, very profound. And this child is having 6966 parts, though the retina looks very bad. Like on picture, it looks like mottled retina, completely pigmentary retinopathy, and this child does not have any night vision or day vision problems. So I don't know whether it's going to manifest more later, or we are dealing with a less pathological variant right now. And also the renal involvement has been noted in IMPP5E also, which may manifest later in life.
Yeah, but usually the oculomotor apraxia is the one which is present since infancy. The renal ones,
Exactly.
the renal thing can happen later, but the eye movement problems are generally noted, in infancy.
Yeah, so I went back to some, I had some videos, thankfully, of this child when she was actually operated by 4 years, I think, with me, but maybe I didn't notice
Yeah.
it then, I don't know, and she had this typical infantile esotropia and nothing else. So I didn't even investigate further because there was no developmental delays or any other problems noted then. So, in fact, I had given her glasses, and we've seen that no improvement was there. So I had taken it as an infantile esotropia and operated. So maybe I missed the oculomotor apraxia is what I feel too. Even now, the
Maybe
video
no,
that I
maybe it
shared
could
was of
be.
another child.
Yeah,
But the oculomotor apraxia is also very subtle, actually. It's like she's
yeah.
managing it quite well. So it's difficult, I guess, to identify
Yeah,
in
maybe
even younger age group.
it was subtle, and or maybe it wasn't there. Maybe it's a new finding in this kind of a disease. So, I mean, Jobert's does have its lot of phenotypic variability because of multiple gene involvements, as you mentioned, and with the depending on which gene you may have the renal symptoms which are more prominent, or the eye symptoms which are more prominent, or other disease which are more prominent. So that is why. So, and can you just show the genetic report once again?
Yeah, if I can manage to share again. Yeah, I'll go to the report. So here, are you able to see it?
Yeah, I have to zoom it a little bit. Okay, so this is a compound heterozygous, and
Yes.
it is, yeah, it is autosomal recessive. Yeah. So, so in a compound and what about the parents and other
Yeah, they
siblings?
didn't undergo actually. There is no sibling. She's the only child. And
Mm-hmm.
unfortunately, the parents are separated. So I mean, they don't have, they've not undergone any testing further.
Yeah. So see, as your phenotype is fitting the genotype, it is
Hmm.
fitting because especially the molar tooth sign is quite striking.
Hmm. Hmm.
Otherwise, with compound heterozygous, the issue arises whether they are in cis or trans. I mean, getting from both the parents or you're getting just from one parent. If you're getting from
Hmm.
one
Hmm.
parent, then you can't prove that this is a significant variant, okay? If it
Hmm.
is coming from both the parents, one from one and one from the other, that means both the copies of the gene are malfunctioning. And then it will
Hmm.
prove that this patient's genetic report kind of proves your Joubert syndrome. I mean, proves your diagnosis.
Correct.
Although phenotype is definitely matching, but then I'm just
Hmm.
thinking because it's a very good case, and in the way that it is just showing us a lot of learning points. Because I never thought that you can know Joberts can be missed in infancy and can be diagnosed at a later age. When you told me it's a Joberts case, I thought it'll be an infant that you are showing or
Yeah.
something like that,
Yeah.
right? Because
Yeah.
most of the time we pick it up.
Exactly the reason I presented, because
Yeah, yeah,
even when she came for a follow-up, it was like the vision is quite good. So you don't actually correlate with retinal dystrophy also. So and she didn't have, and in fact, all throughout after the surgery, she's been lost to follow-up, but she was doing quite well, is what the parents said.
yeah.
And
So
even
you
the head nodding actually now is quite variable. Like there are few months when she doesn't have any head nodding. So I don't know whether the cerebellar signs are not coming or what is it. I don't know.
but the MRI scan showed that there was cerebral vermis
Yeah.
dysgenesis, right?
Yes.
Agenesis
Yes.
which is
Yes.
there.
But yeah,
Yeah, so
she,
I mean, it's a good thing. You should actually try to report it. I mean, it should be go
yes.
as a case report. And even if you test the mother, I think it should be okay. If the mother has just one of them, then
Yes.
definitely the other one came from the father, right?
Right. Right. Right.
So you can just test the
Right.
mother, and if the
Okay.
mother doesn't have both, that means the father has
Yes.
both, and again it doesn't come in trans. It will be in cis. So even with one parent,
Sis.
probably
Okay.
am I right, Nivedita, and any other people who are here?
Yes, ma'am, that would be the correct approach. We can go ahead with testing one parent.
One
I'm just
parent.
thinking that
Okay.
the second variant is a synonymous variant. So I don't
Yeah,
think
yeah,
it will
yeah.
be significant. I
Hmm.
Oh,
was just looking briefly. I saw that there were two patients who had a similar kind of a phenotype where they just had IRD and none of the neurological symptoms, and they were able to find only one variant in those patients. So I'm
okay.
thinking if maybe a single variant can cause a milder disease, because usually these Joubert syndrome patients will have those severe neurological symptoms. I have never seen any patient who's in
Yeah.
the first decade of life. So I'm just thinking that maybe
Mhm.
that one variant might cause something like less.
But Jobert's is usually recessive, no?
Yes,
Or do
ma'am.
we have an autosomal dominant variant also?
Not that I can see.
No, only one
So then you,
excellent, I think, has been reported, isn't it? But autosomal dominant, I don't think is there.
yeah, so then you need both the
Both
alleles
the
being affected,
variants.
right? Although the one was a nonsense, no? Nonsense mutation, one was a missense. You
Yes, yes,
described the,
yes,
I think
yes,
but
first
here
yes.
one
it
is
is missense
missense
in both, right?
and
Here it is
first
said
is missense
missense.
and second is
First is
The
missense
second
and
variant,
second is silent variant.
the second variant is silent variant, but might be close to some splice site. So even the synonymous variant can affect, cause some effect. And as Dr. Shalja, you are saying that yes, it's good idea to test just one parent. The second parent, if it's not tested, and one parent is carrying one variant, that is good enough. It's just that
Mm,
if they are separated, but if they are planning a second child, we need to test the father also, because it may be possible that one variant is coming from mother and the other variant is de novo also. So that would change the
yeah.
risk of recurrence. That would confirm the diagnosis, but still change the risk of recurrence. So only for that purpose we need to check comp het variants in both parents.
Yeah.
But otherwise, even if one variant is segregating, that would in a way and might change the classification also, to from VUS to maybe a hot VUS or something like that.
Mm. So that's why it's
Any
important to
experience with a
report.
visual outcome in these INPP5 gene mutation related Jouberts? How is the visual prognosis?
No experience. I mean, if anybody else has, can speak up, because Joubert is so rare. I have seen one case here in Delhi and one probably during my fellowship.
Hmm.
And those also, I don't think so. It was long time back. At that time, I was very proactively sequencing my patients. So I haven't seen that recently.
Yes.
But I'm just hoping it should be good for the patient because it's a milder variant. Looks like a milder variant.
Looks like a milder variant. Yes, yes, yes.
But as you mentioned, it's important to monitor for the kidney involvement later. As you said, no, some patients have been
Yes, yes, yes.
involved.
They can develop cysts later on also actually. Or
Mm.
even membranous glomerulonephritis can also come in these children. So they need to be monitored.
Yeah.
Yeah. Yeah, look, a nice case. Like actually, we are having series of Joberts, but all bad cases. Like we have never seen. We had a family
Yeah,
who had
agree.
three kids, like three siblings having Joberts, but that was like 4 or 5 years back. We never thought that time of genetic testing, and I think like if we go to more like all the centers which are for muscular dystrophy, Duchenne's, because
Mm.
all these Joberts are usually very bad. But this case is really like we never thought, like I could never imagine like it's such a good
Yeah,
No,
thing.
so
I
that's the thing. The Jouberts that I've also seen back in Madurai are were so severe that it was like
Yeah,
a shouting Joubert. So we never went ahead and even evaluated them and did
yeah,
a
yeah.
genetic
MRI will be so
evaluation.
classical, like
So
everything, like we
classical.
don't have to do anything else.
Exactly.
Mm.
So here, this subtle things, I thought that there are learning tips here that we can, we may miss. And plus, the disc edema was very misleading initially, and then I
Yeah,
couldn't
yeah,
fit it
yeah.
into the picture till I read that optic disc drusen is again seen a lot in Jouberts. So
Yeah,
is
one
there
more question.
any
Like it
other
is not with.
condition in which, yeah, yeah, go ahead, please.
No, no, no. You go ahead. You go ahead. Mine is like simple. I just wanted to. What ERG? You use LKC? What was that ERG reporting?
KCERG, yes, yes, yes.
LKC. Yeah. Okay. 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 Thank you. Okay, nice case.
I was just thinking, what are the other causes of molar tooth sign? Because the entire diagnosis is based on that, right? Is there any other thing
Mhm.
that we are missing here?
So, molar tooth sign, I mean, they have reported molar tooth sign in all other ciliopathies also.
Ciliopathies as
So
well, yeah.
it's, yeah, yeah. So it may not be only in Joubert's because Joubert's related disorders, whatever we know, in that also
Mm.
molar tooth sign may be there. So it's actually, I mean, we need actually some kind of other clinical features also here. So everything is not fitting into the picture for sure. So usually these children are very hypotonic. So I remember very classical Jouberts that we used to see were children with no neck holding and that
Yeah.
classical oculomotor apraxia. I mean, you can't miss it. So those neurological signs are more prominent in Jouberts. But here there is no neurological sign, almost no neurological sign, more ocular signs, and that this. So that's why I feel that maybe, as you say, parental evaluation might give us some more hint
Yeah.
about what is happening. So
Yep, yep.
I'll
And you should
push for that.
definitely try to report it because one, it is a very rare presentation of Joubert syndrome. But before that, as you know, if you can prove that this is really this genetic testing
Yeah,
is
this is this.
holding
Yeah,
true, then it will become a strong case for Joubert's. Otherwise, the only other thing which people might ask, a reviewer might ask is, is there any other explanation for the molar tooth sign because your
exactly.
variants were not likely pathogenic or there's not much evidence. But if you can say that other ciliopathies were all ruled out and doesn't fit into any other ciliopathy, I was just googling it. I was just going to Google and seeing. So there are 5, 6 other
Yeah,
ciliopathies. If she doesn't
MORD
fit
and all
into,
those others. Yeah,
yeah, there's some codes, some VARA-D, some nephronophthisis.
codes and
Most of them,
MORD. Yeah,
yeah, most of them are very
much more
again
severe than
involving
this.
much more severe. Yeah, yeah, yeah.
Much more severe than this. Yeah.
Much more severe than this. So if it doesn't fit, then your case is quite
Would
strong.
you suggest whole exome sequencing for both the parents?
Not really. Even that same variant, single variant can be, tested. Just a Sanger
Single
confirmation.
variant.
I mean both the variants which have come.
Yeah. So only them Sanger sequencing should be enough for both the parents.
Yeah, I think so. I mean, I don't know. Maitri and this can guide. They are ordering more tests.
For further classification, just Sanger for the parents is good enough.
Yeah,
Sanger for the parents. Okay. Okay.
yeah. So, if any more questions are there, great. If there are no further questions, then thank you, Aloka. Thank you for volunteering.
Thank you so much. Thank you.
And
Thank you.
welcome to the bigger family of the OGIG. So
Yeah. Sorry for sounding so naive, and I'm like a fish
no,
in
no,
a pond in genetics.
everybody is naive here. You won't believe when we started it, we had a very small group because we had this doubt that, if we start something like this and we sound so naive, we don't know anything, and we are like, you're starting a group which is a Ocular Genetics Interest Group. But
I'm
then that is
so
from where
obliged to the
everybody
group.
is, that is where everybody started, and we first tried to learn things. And so the best way to learn is to present. Okay, otherwise,
Exactly. That's why.
you would not have looked back or accumulated this patient's previous photographs, videos, everything
Exactly.
unless you would have
Exactly.
presented. So that's I'll always feel that best way to learn is to present. Only then we read, then we really compile our cases. Otherwise, they just lie there. So thank you again
Thank you, and thank
for
you for
picking
the
it up.
group.
And
It really helps us in our daily practice. So thank you so much for forming the group.
yeah, and requesting others who have attended also to, try to look into your cases and share with us so that all of us can learn from each other's experience. Any other, if there are no other comments and, suggestions, then we'll end the meeting here. Thank you. Thank you, Nivedita.
Thank you, ma'am. Thank you, Dr. Aloka.
Thank you. Thank you so much. Thank you.
And it
Thank
was actually a really nice presentation. I think it got all of us thinking. I don't think it was naive at all. It's a
you.
very
Right.
rare
Yeah,
Thank you
yeah,
so
yeah.
much.
presentation, and we have never seen anything like this. So definitely it encourages us to read more and see why.
Thank you. Thank you so much. Bye.
Okay, bye.